Looking forward to have you back here, Samaresh. So, from one star to the next superstar. So, we call him the superstar of Indian ophthalmology because his presentations are mostly international, and to get Ashvin on board is a big thing. Thank you, Ashvin. And he specializes in doing only challenging cases. So, he'll teach you all how to make challenging cases, how they look simple. And he's going to talk on phaco and clouded corneas. Over to you, Ashvin.
More of challenging cases. So I just wanted to showcase, start off with this subluxated cornea, this subluxated cataract which I have. And you can see the amount of subluxation initially. So I'm starting off doing a glued IOL even without removing the lens. Now this is a little tricky. So what I've first done is, because it's a large eye, and I don't think many of you saw it, because whenever you have a large eye, you really have to make a small peripheral iridectomy so that the sclerotomy that you're making under the flaps. So the flaps are made 180 degrees apart, 3 and 9 o'clock position. Once you do that, you make sclerotomies under the flaps about 0.75 to 1 millimeter behind the limbus. Once this is done, you make the peripheral iridectomy. Again, watch here, using a vitrectomy. After doing some vitrectomy under the cataract, of course, so that no vitreous comes in the way. Now you've made your peripheral iridectomy and you've made a sclerotomy under that. Now I'm injecting the lens. Mind you, I've not removed the cataractus lens yet, and I have not even caused a opening yet. I've not made an opening into the lens because that drops lens matter inside. So I'm pushing my intraocular lens under this cataractus lens. And you can see with the red glow itself, you can actually visualize the haptic tip. Once you're visualizing the haptic tip, you can use a bimanual approach, a handshake technique of its own, and actually externalize both the haptics. This way, you've basically gone ahead and caused your own posterior capsule. You've made a posterior capsule that will prevent any cataractus lens to drop once you are doing a phacoemulsification. So this is one method that I've implied. In certain cases, of course, it does not work when the lens is already dropped halfway down or any of those sorts. If you have some amount of zonular support, you can do this. And I'll show you some more tips and tricks on that. So basically, basic idea here is you've caused your own this thing. Now imagine if I had no intraocular lens there, this cataractus lens would definitely go all the way down. So I'm basically removing this cataractus lens. Now once the whole lens is removed, I also have noticed that superior iris is kind of flaccid and not really intact. So first doing some triamcinolone to check if there's any vitreous. Fortunately, if you see in most of these cases, I've never found vitreous come forward unless you have gone and disturbed the vitreous in a traumatic way. I didn't cause any trauma. Here is where I was talking about the pupilloplasty, and my choice of pupilloplasty is a single pass 4th row. If you can see here, I'm bringing out one loop like a modified Seepser, and now passing it 4 times, and just one throw, 4 times, loop and closed. That's pretty much it. I don't even go the second time, third time, because that causes more trauma to the iris, that causes more uveitis the next day and more inflammation. So that's something that we don't try and do. These are some of the post-operative pictures. This is the first day post-op, and here's the 10-day post-op after the bubble was gone. 2020, this patient achieved. Just because of the simple maneuvers that I did right, probably also luck played a big favor here for me. I just wanted to showcase this. Okay. Sorry about this. Sorry, 1 second. I'm just going to. I don't know what's happening.
It's coming up.
Yep.
Ashvin.
Yeah, can you see it up there? Yeah. Sorry about that, guys. Okay, so this is an intraocular lens drop. There's an intraocular lens that dropped inside the eye post-operatively, and I wanted to see if we can actually go ahead and remove it using a different technique. And scleral tunnel is a great approach for this, to actually explant this technique, but I wanted to use a different approach. So first up, I know I have to do a scleral flap. 180 degrees apart. So I'm using a 3 millimeter by 3 millimeter L-shaped incision. The L-shaped incision actually basically helps in reducing my astigmatism, making a smaller entry point, and removes the lens without any struggle. So I've made my flaps, made my sclerotomies and my side port entry. I'm using a triamcinolone to kind of remove any vitreous in the anterior chamber, doing a posterior vitrectomy as well, going ahead and removing all the vitreous around the intraocular lens. Once this is done, I'm using a ECAL technique, that is an extrusion cannula assisted levitation. So basically I don't use a forceps or anything like that, especially in these where you have a bag IOL complex completely down. All you have to do is do that, and once you have done with that, you basically use that L-shaped incision to kind of remove this intraocular lens. Now once this is done, you take the intraocular lens into place, again using the glue dial technique, handshake over here, pull them inside and close this wound with sutures if need be. If you don't want, that's also fine. I use it as stay sutures because some of these patients post-operatively are older and they play with their young ones and they kind of get hit sometimes, and I've seen that before. So I kind of try to have stay sutures put in place just for avoiding trivial trauma causing any injuries. That's one of the ways of removing these, solving these problems. Another case that I wanted to talk to you about is sombering ring. And how many of you over here actually try and take care of sombering ring once you see it, or do you just place a intraocular lens or ACIOL? How many of you take care of the sombering ring, or you remove the sombering ring? So one of the reasons in these kind of cases I definitely try and remove is two. One is there is always going to be some amount of tilt if I do place them, one. Second is in case they do fall during the surgery, then I have no option but to go ahead and take it off from the posterior segment. And that's something that I don't want to do. I try not to do as much as possible. So keeping this in mind, here I'm making my scleral flaps here. Once I've made my scleral flaps, here's 2 by 2 millimeters. I put an AC maintainer, but I put a trocar AC maintainer, which basically gives me self-sealing wound and continuous infusion of fluid inside. I've made my entries, my sclerotomies, as well as doing my anterior vitrectomy, which in these cases, more often than not, you don't really need it, but it's always good to have anterior vitrectomy being done in these cases. Push in your foldable intraocular lens. Using a handshake technique, externalize these to haptics, but invariably what happens in these cases is the pupil shuts down. And once this pupil shuts down, you can't actually see the sombering ring. So what I started to do in these cases is basically quadrant by quadrant. After first stabilizing the lens, I remove 2 iris hooks, use those iris hooks ports as 2 entry points to quadrant by quadrant segmentalize this sombering ring, bring it into the anterior chamber and burp it out. So that's one technique. You can do that with smaller pieces in a longitudinal fashion which are there currently. So the smaller pieces do come out just by burping technique using the pressure gradient. So basically you're trying to say point of least resistance is where the piece will try to come out. If your point of least resistance is south, it's going to go down south. Now this piece, the last piece over here, if you see, invariably is very large. So you actually have to use a phaco probe to do it. You cannot take this off with a cutter. You cannot take this off with any other instrument except a phaco probe, which can be done in 30 seconds or less. Vitrectomy possible, but you have to actually chew up the pieces, and the pieces invariably fall down without doubt. Again, doing a pupilloplasty invariably supports preventing an optic capture, and that's something that you really don't want in these cases. Another case which I wanted to show you is a traumatic case where you have a small amount of a small trauma on the side, but more importantly, it's also caused the iris root tear as well as the iris leaf, that is the pupillary tear. So the iris is basically torn all the way. And what I've done in this case is basically put in some trypan blue, checking anteriorly there is a attachment, there is some form of fibrous attachment to the wound itself, and this is something that you will see with some posterior synechia. Now, upon doing this capsular access here, I've already noticed that there is a tear on the anterior capsule, and that's why the cataract is length. So whatever rest was possible, I was able to complete the access on the other side, but it was not a CCC. There was an element of capsular tear. So, and it's a very milky kind of cataract, but you see the bag, the sheen on the bag is very, very abnormal, and it's very abnormal because of the injury. And if you see over here, there is a straight fibrous band extending all the way from the bag to the corneal wound, and this is something that you will see in certain cases where there is already an attachment from the vitreous. So I had to actually cut it with a vitrector. Upon cutting it with the vitrector, I did notice that there was some amount of vitreous coming through that. And once I found vitreous, I don't like to place anything, especially if my anterior rim is not intact. If my anterior rim is not intact, I cannot place it in the sulcus. I cannot go ahead with the surgery because vitreous at some point is going to come on top. So, and also, see the bag. It's not a clean bag. It's not going to have the visual potential that I would want in a patient like this. So I always try and do a posterior just so that to ensure that no pieces fell down, and unfortunately nothing fell down. Try as much as possible to keep the capsular margin rim over here, and I'll tell you that later. But after you've externalized the haptics, you tuck these two haptics inside so that to stabilize the bag. Now you actually have to, I've put some triamcinolone to kind of check if there's any vitreous in the anterior chamber. Fortunately, there was not much. But more importantly, now I have close to 180 degree of iris tear. If you see, there's an iridodialysis, there's an iris root tear, and there is a pupillary tear. So it's a complete all-around wound. How do you handle these situations? By simple salvaging the iris tissue. So first up, treat the root. Don't take care of the iridodialysis because that can be taken care second. First up, treat the root of the iris. If you take care of the root of the iris, you have your leaflets ready for later on. But let's watch. Let's analyze one step at a time. So the idea here is to first take care of the root. Now, using a pupilloplasty, that is a single pass 4th row, you're doing a root repair. Once this, you pull the two ends apart, you have these two joined. Now you still have to analyze again. Now watch what I have here. I have 180 degrees of, close to 180 degrees of iridodialysis. Now this I cannot leave this patient like this. It's going to be this is completely coming into the pupillary zone, the iris. So this is not normal. Now, using the flaps of the glued IOL, I'm doing a iridodialysis handbag technique. So basically 2 sutures, double arm, passed through the same end, through an incision on this side. There is a side port incision here. Through the same incision, make sure that you don't get corneal tissue entangled in any of those sutures. Pass them, pull them all the way, it comes all the way to the periphery. Once you tighten them, and you can always close them under the flaps. You can close them under the flaps. You really don't have to bury them or anything because the flap takes care of the cover. Once you have this, I still have this nagging optic which is showing up over here, and I don't like to leave a patient like this. So to ensure that I have, now you can do the leaflets. If you had taken care of the pupillary zone first, you wouldn't have these leaflets to take care of later. So you actually have to go with the root first, then treat the iridodialysis, and the last be the pupillary zone. Once you're done with this, you actually have, you won't have a round pupil, but you can attain a round pupil by doing 2 steps, which I probably didn't do, but I'll tell you that over here because I started doing them later. This is the post-operative day 1 and day 3 of the same patient. Patient attained
Ashvin,
a
can you just wind up?
Yep.
Yeah.
So this is patient achieved the 6/9 vision in this case. So the 2 tricks over here would be to actually do a cautery, which would make it round. If you do a cautery, it pulls the iris away. And that's one method. And the second is doing a vitrectomy. Use a vitrectomy to make that pupil round. These are 2 tricks which I started to use now and learned by Brandon Ayres from US. All right. Thank you so much.
Thank you, Ashwin.
Thank you.
I think people who are interested in learning more of the glued IOL, they have a wonderful conference, IIRSA in Chennai, and they have wonderful wet labs. So I think that will be the best place to actually go ahead and learn these glued IOL techniques. Any other questions to Ashwin? One?
How many of you are doing glued IOLs in this audience? Yeah, quite a few of them. I think glued IOL, the IOL scaffold and the SFT and the pinhole pupilloplasty are great innovations from Amar Agarwal. I think we are all using that, and quite good, very good demonstration, nice, incredible videos by Ashvin as well. And we'll discuss that probably the end of the session.
Sure. So next we have